Hello, everyone, and welcome to another episode of the Overcoming Chronic Illness podcast. My name is Dr. Bryan Rade, and I'm a naturopathic doctor. And today I am going to talk to you about the Neural Zoomer Plus. You can see in the background here of my screen, if you're watching this on YouTube or YouTube's the only video platform I use. If you're watching this on YouTube, you can see that I have a report up in the background here, and I'm excited to talk about this report because it's something we've been using at our clinic for a little while now. Been running it on lots and lots of patients, and it's something that I found to be really, really useful. Um, So, as per usual, nothing that I'm saying during any of these podcast interviews or episodes should be construed as medical advice. This is all for informational purposes only. And if you need healthcare advice, please talk to your healthcare provider to get that advice. This test is offered by a lab based out of the US called Vibrant Wellness. And Vibrant Wellness offers a whole range of different testing assays. So I'm going to talk about the NeuroZoomer Plus today. If there's interest, there's some other profiles that we run of theirs that I'm happy to talk about as well. There's one all about autoimmunity. There's one that gets into specific ways that folks react to foods. So it's different than standard IgG for food sensitivity testing. And so I might do a video on that or post a podcast episode about that at some point. So we'll see how much interest there is in this topic and kind of base it on that. With the Neural Zoomer Plus, there's a few cases that I want to go over because I'll talk about what the test involves, talk about the different things that it tests for, but then I have a few sample reports here from some patients that I've like real life patients. Obviously, the big black box in the upper left corner there. I've blocked out their names, obviously, for confidentiality purposes, but I'll go through a few sample reports and give you a bit of a sense of the clinical flavor of what this actually looks like in clinical practice, and we'll just see where the conversation goes. Um, so the NeuroZoomer Plus, it tests for 47 different markers that relate to nervous system function. The majority of those markers relate to central nervous system parameters, so central nervous system being the brain and spinal cord. There are some markers that look at peripheral nervous system health as well. So peripheral nerves being our spinal nerves, basically all the nerves that are outside of our central nervous system. And then there's also a section, as we'll see here coming up, that looks at antibody levels against different viruses and also streptococcus. So a bunch of viruses plus strep being the special bacteria that gets special mention here in the report. And the reason that we care about strep and these particular viruses is that they are implicated, or they can be implicated in different neurodegenerative conditions or neuroinflammatory conditions, such as Alzheimer's, such as multiple sclerosis, such as PANS or PANDAS, which are pediatric specific conditions. Have some other podcast episodes and other videos on social media talking about PANS and PANDAS. If you're not familiar with that, please cross-reference that if you're so inclined. And so it measures a whole whack of different markers related to nervous system function. So as we can see here on the screen, I'm really hoping that my little picture of me is not blocking anything crucial here. So hopefully that's good. So I'll move things around a little bit, and if it's blocking, hopefully things will be unblocked if needed. Also, if you want to cross-reference one of these reports, you can just go to the Vibrant Wellness website, and they have sample reports of all the different tests that they do. Now, I do want to clarify that I have no financial interest or financial relationship with Vibrant Wellness. This is just a lab that we use for our patients. When our patients do testing through us, they pay the lab directly. We make no money whatsoever if they do the testing through our clinic or not, and I'm not financially involved. So I just want to clarify I have no conflicts of interest with talking about the Vibrant Wellness report. It's just a test that I found to be useful and wanted to share it with my audience. All of the parameters that are tested or all the markers, I should say, that are tested within a NeuroZoomer Plus are antibodies. So if we take a look here, and oh my gosh, yeah, I don't usually use a cursor here, so I'm not gonna point with my little pointer because I'm not sure if it's actually going to come up or not. So I'll just verbally describe what I'm referring to here. So if we look at the left-hand column, there's the list of the various antigens that are, in this case, demyelination antigens that are being tested. Then the next column over at the top there, it says IgG plus IgA. So that refers to these different antibody types. So we have, IgG antibodies, IgA antibodies, IgM antibodies, IgE antibodies, and IgD antibodies. And so this is looking at the sum total of IgG and IgA antibodies. The significance of that is that IgG and IgA antibodies are the antibodies that we have that are kind of like the memory antibody response, the longer standing, longer lasting antibodies. So the analogy that I use is that if, say, someone has um, say someone lit a fire and there's a fire burning as a consequence of lighting that fire. The IgG and IgA antibodies are essentially telling us that someone lit a fire at some point in the past, but there's not necessarily someone currently lighting more fires. So the fire's been lit and it's burning away. The next column over, which is the IgM antibodies. So IgM antibodies are generally the first line of immune system response that we have to an infection or if there's an autoimmune process going on. So the IgM antibodies are really more indicative of whether there's some active fire lighting happening right now. So if there was, say there was a forest fire and we just hear that, like, well, there's a forest fire. Well, and that's all the information that you have. It's like the question is like, well, did somebody light that fire, days ago and it's been, burning ever since? Or is there someone that's actually that, say, lit the fire days ago and they're actually still going around lighting more sites of the forest on fire? So that would be the IgM antibody levels would be reflective of that. So again, generally speaking, IgM is the first type of antibody that occurs when there's an infection or an autoimmune process happening. The IgG and IgA are kind of like the perpetuating antibodies that kind of keep the ball rolling with that inflammation, with that immune system response that's going on. So I'll get into the weeds or the specifics of why that matters or why it's good to have that differentiation moving forward with some of the specifics of some of these reports we're going to look at. But that's the backdrop. Now, if we move further over to the right, you can see there it says previous IgG plus IgA and previous IgM. So there's nothing there because this is the first test that this patient had. So down the road, the plan is for this patient to do the test again, after a few months, maybe 3 to 6 months of treatment. Then we're going to look and see how those levels are looking, and hopefully we're going to see improvement. That's the plan. And of course, if there's not adequate treatment, or maybe if the patient chooses to not undergo treatment, or if some other factors conspire, of course, certain things could look worse over time. So one could use a NeuroZoomer Plus to as another metric to track how an autoimmune process is progressing, say something like multiple sclerosis, or how a neurodegenerative condition like Alzheimer's or Parkinson's is progressing. So, of course, we generally want those conditions to improve or at the very least stabilize. But of course, those are neurodegenerative conditions, so they can get worse over time. So when we're comparing the previous results to the most current results, then we're getting a sense of things getting better, getting worse, staying about the same. And the immune system, at least the memory aspect of the immune system, that IgG, IgA, that generally tends to move pretty slowly. So we, wouldn't really, generally speaking, wouldn't really expect to see a dramatic change in the levels of these antibodies in a short window of time. That's why we would generally want to wait, in my opinion, at least in my experience, like at least a few months before we'd want to retest antibody levels against X, Y, or Z agent or substance. So let me see. I think that's so the last thing I'll mention here before getting into some of the specifics here of this particular test result is that so at the end of a NeuroZoomer Plus report, there's a list of all the antigens that are tested for. So as we're seeing here, the antitubulin, anti-myelin basic protein, anti-myelin oligodendrocyte glycoprotein, et cetera, et cetera. And so this is going to tell us about all the levels that are the results for all the different antigens that were tested, whether they came back looking normal or they came back looking abnormal. The earlier, further up on the report, if you kind of look over to the right side there, you can see the slider bar on this PDF file is, say a little over halfway down the document. So further up, we can see that they actually summarize all the abnormal findings. So with this report, we'll just go through the the full list of antigens, so to give you folks a better sense of what the report actually looks at. Then for the next couple, we'll just look at the summaries to see, what actually came up. So they kind of categorize it or organize it a bit, which is handy and lets us go over things a little bit faster. It's nice to see this section though, I think, because it gives us a better sense of like all the different antigens that are tested for, and it also gives us a better sense of, to what extent are the any positive findings, like any, any non-control findings actually relevant. So, for example, here in this demyelination antigen section, there's the 6 different antigens that they test for. We can see that only one of them has come up positive, and it's quite mild at that. So overall, it does not look like this patient is dealing with, in my opinion, is not dealing with significant amounts of demyelination. So we're probably not overly concerned about, the integrity of their myelin sheath. As a point of reference, myelin is the essentially the sheath or the insulation that goes around many of our nerves, and that insulation allows for more efficient conduction of electricity down those nerves. So just like if you had a wire in your home, there's an insulation around it so that the electricity is not just flying off into the ether. You want it to not, set off sparks and set your house on fire, but then you also want it to travel nice and efficiently from, one end of the wire to the next, so that your light switch turns on or your laptop charges or whatever it is that you're working with. So with myelin, if there's a degeneration or degradation of the myelin, then that's going to lead to a compromise of the nervous system function. And the classic example of that would be multiple sclerosis, where there's an attack on the myelin sheath. So in this particular case, we can kind of look at this. So if we were just looking at the summary section, we saw like, oh, that anti-myelin proteolipid peptide, like that came back as, something came back there. It's like, oh, maybe I've got some demyelination going on. When we look at this in context with all these other demyelination antigens, like, well, maybe that's actually not such a big deal. And before moving on with this report, just looking in the top right corner there, let's just quickly talk about what the relevance is of these various numbers. So as you can see there, the reference range section in the top right corner. So green is generally good. Rare to see a report where green is bad. It's kind of funny because if you're feeling green, you're feeling sick. But anyways, it's all relative, or it's all contextual, I guess. So the green means in control. So any number that's less than or equal to 10 would be green, or any of the numbers that come up black are within the control. Moderate would be 10.1 to 2, or yellowish orange, and then anything above 20 would be red or in a risk category. So the reason that they frame it like this or phrase it like this is that because you might think like, okay, these are autoimmune antibodies, or antibodies against tubulin and myelin and these different things that are coming up, or that are listed here. So wouldn't any number be bad or problematic? Like, should we not have 0 of all of these different antibodies? And that's a really great logical question, but the answer is no. It is acceptable or normal to expect low levels of these antibodies in healthy folks, and we have sort of a comparator for that with just more standard labs. For example, if one was to go to, see their family doctor or nurse practitioner, naturopathic doctor, whoever, and like just get standard, say, anti-thyroid antibody labs, there's a reference range. So the range depends on the lab, depends on the marker. But say for anti-thyroid globulin antibodies, one of the labs we use, the reference range it's supposed to be less than 115, and if you're less than 115, that's considered normal. So in other words, when they do the test on healthy control subjects who have no thyroid issues whatsoever, their thyroid looks to be as healthy as possible by all measures. It's normal to have, say, like an 80, a 50, a 30, a 114. That's all considered normal for antithyroid globulin antibodies. So it seems kind of counterintuitive that a perfectly healthy person would be walking around with these antibodies that are geared at attacking the thyroid, but that's the way it works. Now, do the patients actually have those antibody levels, or is it more that the assay, the testing reagents are maybe cross-reacting with other things? And like these are details that I do not know the answer to, and because I don't know that that's been thoroughly explored, because I don't know how you would actually determine that in a at least in human controls, or in human subjects. But it is the punchline is that it is normal, it is expected for healthy controls to have very low levels of these, like relatively speaking, low levels of these antibodies. So just in case anyone was wondering, that's why 0 is not considered to be the normal baseline. Anything less than 10. So moderate being between 10.1 and 20. So sort of saying moderate, like, well, what's moderate? Well, they're referring there to say like moderate risk, or moderate possibility that this is causing a problem. So with these, many of these antibodies, when you do a deep dive into looking at what the research literature says about these antibodies, for a lot of them, they are either have not been studied outside of an animal model, just saying that like, oh, we had an animal model of MS, and we found anti-tubulin antibodies in 30% of them or something like that, or maybe there are some human trials that have been done, or human studies that have been done, saying we took blood samples on 100 patients with Parkinson's, and we found anti-dopamine receptor antibodies, but we don't yet know what the definitive clinical relevance is of that. So with this test, like with the NeuralZoomer Plus, now, and then there are some markers that they test for that have been very well studied. So with the NeuralZoomer Plus, there are it's the way I sort of the way I conceptualize it is that they're casting a very broad net. They are looking at really, I think, all of the possible markers that they can test for. They're looking to see, what are the levels of those antibodies, whether IgG, IgA, or IgM, and then presenting that data. And then it's up to us as functional medicine practitioners to figure out what that means. What's the clinical relevance of that? And then also being able to track that data over time. So, for example, if I had a patient who had symptoms that looked very much like MS, yet they have an MRI, their MRI comes back looking normal. They say have a lumbar puncture / spinal tap. That result comes back looking normal. The neurologist says like, it looks like MS, but like we're really not sure. We're just going to monitor you for a while. Say the patient's having, just some episodic symptoms or maybe some mild symptoms, but they're just kind of monitoring. Well, this might be a very appropriate time to run a NeuralZoomer Plus test. Again, not giving medical advice, just talking anecdotally here or just talking academically. But this might be a really great time to run a NeuralZoomer Plus test in a patient like that to see what comes up. And if this demyelination section comes up, lighting up like a Christmas tree, or maybe not like a Christmas tree, but if we saw a bunch of orange in the IgG, IgA, or IgM section, say like, well, that's not super high levels, but we probably shouldn't be seeing those demyelination antigens. So for example, this patient has a diagnosis of Parkinson's disease. So Parkinson's, being a loss of dopaminergic nergens in the substantia nigra region of the brain, and nothing really directly to do with demyelination at all. And so with him, even though his symptoms have, progressed to a certain point, and thankfully is, doing quite a lot better clinically with treatment, which has been great. Despite that fact, despite the fact that there is this neurodegenerative picture, like his demyelination antigens really look very uneventful. Almost everything is black. There's just a very low moderate there at an 11.8. So if there was, say, a person who's, say she's in her 30s, she's having some classic symptoms of MS, this all the MRI and everything looks normal. And then she comes back with, say, a bunch of like 15s or 18s, or, maybe some low 20s in the demyelination section. I'd be thinking like, this is probably really relevant. This test is probably, it seems to be picking something up that, the MRI hasn't quite caught up with yet. There hasn't been enough damage yet or demyelination to actually pick up those white matter lesions on the brain or on the MRI. But this test could be really useful in a case like that. And then where it would be further useful, in my opinion, or in a scenario like that, would be that with treatment, so let's say we started on some anti-inflammatories, some immunomodulators, some things to help support the function and integrity of myelin, or the synthesis of myelin, etc. Then she's like, hey, I'm feeling better. Well, I wonder how my brain's doing. Well, the MRI is not going to be helpful in that case because it didn't show any problem in the first place. So a follow-up MRI could, of course, show whether or not things had progressed despite her feeling better in this hypothetical scenario. But you're not going to use a follow-up MRI to track progress because it already looked good in the first place. She's not going to go in for a follow-up spinal tap because everything looked good in the first place, and they don't follow up with spinal taps anyways for tracking progress. Very invasive, and try to minimize those as much as possible. But doing another NeuralZoomer Plus could be really useful, in my opinion, likely would be very useful in a case like that, because we can see, hey, are these antibody levels coming down? And I know if it were me, if I had those, MS-like symptoms, I would be wanting to treat until my NeuralZoomer Plus looked 100%, because I would not want those antibodies to be present at all in my system. So that is the backdrop for the NeuroZoomer Plus. I will now move through the markers here for this particular patient and give you a better sense of all the things that are tested for. So, with the so the first section here is the demyelination antigens, as already discussed. The next section here is looking at blood-brain barrier disruption. So the blood-brain barrier, as I'm sure everybody knows, is that junction between the bloodstream and the cerebral spinal fluid, the fluid that bathes the brain and spinal cord, the central nervous system. What folks may not know is that, like what's so special about the blood-brain barrier? Like, how does that work exactly? And just to give a little bit of insight there. So my understanding of it is that our all of our endothelial cells, so the cells that line our blood vessels, they're connected by these proteins that form what are called gap junction proteins, and they, of course, keep things pretty tight together because otherwise we'd just be oozing blood into our insides through our arteries and veins and would be a big mess and would not be good, would not survive very long. Um, Whereas at the blood-brain barrier, and I'm blanking on the exact numbers here, but I think it's something like 10 to 30 times more. The junctions are 10 to 30 times more tight, or something like that. It's like a markedly greater amount of tightness between those blood vessels. So it's much harder for things to get in and out of the cerebral spinal fluid, which makes sense because the brain is very important and very sensitive to toxins and various things like that. So we want to make sure that it's not getting easily exposed to infections and metabolic waste products and impurities from the environment and things like that. Unfortunately, when there is nervous system when there are neuroinflammatory conditions, neurodegenerative conditions, which are always neuroinflammatory in nature, or there's autoimmune conditions affecting the brain, then the blood-brain barrier can get disrupted, and we can develop what they sometimes refer to as like a leaky blood-brain barrier, just like people talk about leaky gut syndrome. People talk about leaky brain syndrome or leaky blood-brain barrier. So as we can see here with this patient, really nothing eventful coming up at all with his blood-brain barrier, which is great. Now, again, with this patient, in history of Parkinson's, was already doing quite a bit better. Like he'd been on some supplements, some dietary changes, was working with some neurofeedback, so was already doing quite a bit better before we did this test. This was more of like a check-in test. And so would have been interesting to have a baseline before we started all of that, but anyways, this is the information we had, and maybe it looked fine in the first place. Hard to say, but as we can see there's 4 different markers looking at blood-brain barrier disruption. The next section here is looking at optical and autonomic nervous system disorders. So another 4 antigens there. So as we can see there, the anti-aquaporin 4, which are water channels, to my understanding, my recollection, the most prevalent water channels in the brain. So those can be significantly impaired by neurodegenerative and neuroinflammatory processes. As we can see there, is IgG, IgA is greater than 30, which is the highest result you can see. If you recall from the first page, or further up this first page, the reference range says anything above 20 is considered a risk. And so we're really paying attention to anything that's above a 20. Greater than 30 is the highest number that we can see. So whether a patient's actual result was 31, 40, 50, 60, 80, all that the assay can report is greater than 30. So we don't have a specific number there. We just know it's very high. And we can also see there that the IgM antibody level is at 13.7. So not only does it seem that the fire was, a fire had been set in the forest, but it looks like there's still some active forest fire setting as well. So this would be a good example of where, my clinical approach would be to say, like, okay, we definitely want to reduce the inflammation. We definitely want to work with some immunomodulators, but we probably want to be a bit more aggressive in terms of saying, like, well, let's really make sure we're getting on top of those immunomodulators because we know that there's some active fire setting happening. But then also looking to see, is there some trigger for this that hasn't been addressed yet? So are we missing the mold exposure? Are we missing some underlying infection? Um, are we missing food sensitivity? Is there like a leaky gut syndrome issue that's causing more endotoxin to release into the bloodstream, and that's maybe contributing to this. So it would usually mean we want to do a bit more digging, see what's going on. Now, a 13.7 isn't super high, and again, without the privilege or benefit of having a baseline result, then we really don't know what that level looked like before he started treatment. So it may be that had we done this test a few months earlier, maybe his level was at an 18 and now it's down to a 13.7. Maybe it was at a 22 and now it's down to a 13.7. Maybe it was at a 13.7 and it's still a 13.7. We really don't know. So when we eventually do a follow-up on this, then we'll have more insight. All right. And then the next section here is looking at peripheral neuropathy. So as I mentioned at the start of the episode, most of these markers relate to, are specifically looking at the central nervous system. However, there are some that look at the peripheral nerves, so those spinal nerves. So if I had a patient who had, say, otherwise unexplained peripheral neuropathy. So, they're non-diabetic, they didn't have an injury. There's really no obvious reason why they're maybe having burning symptoms or like they didn't have like a, spinal cord injury or like a disc herniation. Like maybe they have, weakness and tingling in their lower extremities and, everything's been ruled out, but we can't figure out why this is happening. These would be useful markers to look at because maybe there's some peripheral neuropathy going on. Now, this particular patient, he doesn't have any really obvious peripheral neuropathy symptoms. Now, I mean, he is an older gentleman, um, you know, so maybe if he was to really put on his thinking cap and say like, oh yeah, like maybe I don't have like, quite as much sensation in my feet as I did once upon a time, or, maybe, as folks get a bit older, oftentimes they'll feel a bit more, stiff, when they first wake up in the morning or just not quite as limber, maybe that's some reflection of some underlying peripheral neuropathy going on, but levels really aren't looking bad. Now, it is, just worth paying attention to, in my opinion, that, that anti-GM1 is at 14.6 for the IgG-IgA. So we know like some fires were set, but there doesn't seem to be active fires happening with the anti-GM1 antibody specifically. But then that anti-GM2, while the IgG-IgA looks good, the IgM is a very, very mild positive. So, something where he's not having any obvious peripheral neuropathy symptoms. I'm not getting into, we're not like specifically targeting that, saying like, oh my gosh, you should be on, like high dose R plus alpha lipoic acid and acetyl L-carnitine, and high dose methylcobalamin, like active form of vitamin B12, and all the things that we would normally throw into the mix to help with peripheral neuropathy. But we'll definitely be keeping an eye on these levels with a follow-up test, and hopefully with is I recommended immunomodulation for this patient, like immunomodulators and anti-inflammatories for this patient, based on these results. And so when we do a follow-up, a few months down the road, then we'll see how those levels are looking. And as I'm saying this out loud, I'm thinking I'll probably do a follow-up podcast episode, at least some follow-up social media videos, going over, how do the follow-up results look like, so we can take a look at those, because that might be of interest. But overall, does not look like there's a ton of peripheral neuropathy going on. So the next section here, looking at markers for neuromuscular disorders. So this gets really interesting to me, anyways. Maybe to others. I hope there's some interest, anyways. Where when patients have Parkinson's symptoms, of course, there's a lot of issues with their movement, right? There's tremors. There's their gait is affected. Sometimes their ability to their speech is affected. Their balance is affected. So we think, well, yeah, that sounds neuromuscular, and yet we look at this patient and we see that like, nope, that's all. It really looks very uneventful. Some very, very mild positives there, but really nothing major coming up. And then of course, when we know it's Parkinson's, well, of course it's a dopamine related issue, and the loss of dopaminergic neurons is what's going to drive those symptoms. We can see on a neuromuscular level, everything is looking really good. Now, the next patient's results that we'll look at here, this patient actually has some notable levels of, I believe it was the anti-voltage gated calcium channels. Might be potassium. I'm pretty sure it was calcium. Maybe it was potassium. I can't remember now. Anyways, with this other patient who has an MS, not this patient, but the next report we'll look at, is a patient with an MS diagnosis and has a lot of neuromuscular symptoms that are just really, unfortunately, not responding to treatment. And we saw one of those channels lit up like a Christmas tree. I think it was the potassium, now that I think of it. So that was, seemed to be very, very relevant to his case. But with this patient, things are looking good. The next section here is looking at particular markers of brain autoimmunity. So this, as we can see there, so looking at cerebellum, like anti-cerebellum antibodies, cerebellum being part of like in the back of the brain, which relates to the area that relates to your balance or our balance. It's also involved in a lot of other processes too. There's a really great podcast interview that I listened to. There's this doctor down in the States. She works out of Daniel Amen's clinic, I believe, like the Amen Clinic, where they do a lot of brain scanning, brain mapping, like SPECT scanning, things like that. Her name's Dr. Ebony Cornish. I've heard her speak about a few different topics. She's quite varied in her topics that she talks about. She talks about I've heard her talk about the cerebellum now, and then also she talks about Morgellons disease, which is quite a rare condition, but like when you have it, like dear God, you really want to make sure you have a clinician who knows about it because it's a really debilitating, challenging condition. And so, anyways, Dr. Cornish was talking about how the cerebellum is actually involved in so much more than just balance. It's involved in a lot of different, like emotional processing. It's involved in different, higher level nervous system function. Like so, of course, every region of the brain is important, and there's interplay between, all the different regions, to a large extent. The cerebellum is just more than just for balance. Anti-Purkinje cells, which is also related to cerebellar function, anti-Yo antibodies, which, if memory serves, are also related to cerebellar function. Then the anti-amyloid beta markers that relates to beta amyloid plaques, which can form, which are kind of a hallmark of Alzheimer's disease. So if we see those antibody levels coming up, then that's where we start to get a bit concerned that like maybe there's this neurodegenerative, some uh, pathophysiology that would potentially lead to dementia on the horizon. So the third report that I'm going to go over goes into um, uh, uh, well, we'll see those come up in the third report that I'm going to talk about. So anti-rage peptide, thinking like, oh my gosh, like anti-anger peptide, like what a funny acronym. But it's RAGE is an acronym, I believe, for receptors of advanced glycation end products. So that has to do more with like blood sugar dysregulation. If there's these glycation end products, it's where like basically elevated blood sugar levels lead to accumulation of these AGEs, advanced glycation end products, which are highly deleterious to the health and integrity of the central nervous system and can predispose to amyloid plaque formation and neuroinflammation. Anti-tau protein, so the tau is also part of those. Part of the pathophysiology of Alzheimer's, and then different neurotransmitter antibodies. So glutamate, which is a neurotransmitter in the nervous system, dopamine, of course, being a neurotransmitter, other elements here of related to like neurodegenerative propagation. So as we see here with this patient, overall, he's looking pretty good. I mean, there were some balance issues, which, with Parkinson's, that kind of goes with the territory in a lot of cases. But 15.6, it's, something to pay attention to, but nothing terrible with that anti-cerebellum protein, or antibodies rather. The anti-tau, it's like, okay, something where we're already getting on top of his brain health like white on rice. So we're going to hopefully see that anti-tau coming down because that is involved in the development of Alzheimer's potentially and down the road, and then the anti-rage peptide just being quite low. So generally speaking, he's doing a good job with his diet. He's again older gentleman, so blood sugar regulation gets a little bit harder as we get older, unless we're really being on top of things. But we're tweaking his diet a bit as well. It's work in progress, so nothing too crazy coming up on the brain autoimmunity section for him. Brain inflammation really doesn't look too bad with the anti-NDMA receptor, anti-AMPA receptor, anti-GABA receptors. So looking, pretty decent, all things considered. Again, he was already doing better before we did this test, so hard to say what it looked like at baseline, but looks pretty good. And then just moving on, oopsie-daisy. Moving on through with the more brain inflammation indicators. So yeah, some of these markers looking really good, but then seeing these anti-Casper antibodies, which is associated with neurodegeneration being quite high. And then really what, stands out like a sore thumb or sticks out like a sore thumb is these anti-dopamine receptor 1 antibodies, which are, as high as they can get, or like it's the highest reading you can get from this type of test, and then the anti-dopamine receptor 2 antibodies, also elevated to some extent. So those are numbers that we obviously are really interested in targeting. Now, it is good to see that the IgM antibody levels for both of those look really good. So those are nice and low within the control range. So suggesting that like yes, the fire was set, but there does not seem to be evidence of like ongoing additional fire setting. So that's really great to see. But yeah, we really want to track those numbers. That's really probably the most important thing to get on top of. The very last section here is looking at infection. So this is where it gets quite nuanced, and this is where it's also really good to look at the full report findings, not just what comes up on the summary, because here we can see, like, okay, the cytomegalovirus gly-B came back positive for IgG, but everything else for cytomegalovirus looks good. Or with Epstein-Barr virus here, we can see that the EBNA, the Epstein-Barr nucleic antigen, came back as a very mild positive. The viral capsid antigen came back as, pretty notable positive, and then everything else looks good. So when we see results like this, it basically tells us that, to my understanding, at least, and again, not medical advice, but it tells me that this patient has been exposed to the Epstein-Barr virus, but does not seem to have Epstein-Barr virus reactivation or chronic EBV, which is really great. So this tells he's been exposed, but it does not seem to be an ongoing issue. Same thing with the cytomegalovirus. We see his HSV1, so herpes simplex virus 1, which causes oral cold sores. HSV2 usually causes genital cold sores. There can be overlap between those, but that's the case. Looks like he's never been exposed to the herpes virus, which is good and kind of rare because over time, a lot of folks have been exposed at least to the HSV1 virus type. Just sometimes it just stays in dormancy for their whole lives and they never know it. But anyways, he's never had exposure by the looks of it. HHV6, HHV7 all looking good, and then streptococcus came up through the roof high. The relevance of the streptococcus being elevated for him, hard to say. There are some really interesting animal studies that have been done showing that the more strep an animal gets, the greater the risk of autoimmunity for their brains. And that's why, the condition pandas, pediatric autoimmune neuropsychiatric disorder associated with streptococcus, i.e. streptococcus triggers this autoimmune neuropsychiatric disorder in kids. So that's why strep can cause that, really what can be a very severe debilitating condition for kids. We don't really know definitively what the relevance of that is in adults. So I kind of look at this as saying, like, well, you've had strep, you have high levels of antibodies against it, and it might be something that is contributing to the pathophysiology, maybe, but it doesn't really necessarily change our game plan necessarily. In some patients, we will really take that to heart and work with low-dose immunotherapy for strep. We'll use nasal sprays and throat sprays to try to bring down strep titers if we think that's relevant. So it can be relevant in some cases. In other cases, it might just be more of an incidental finding saying that, like, yeah, maybe the strep led to a lower threshold to develop an autoimmune condition affecting the brain, but it's not necessarily something that's causing an active issue right now. And just where we're seeing those IgM antibodies being low, it's wouldn't be the front and center thing that we necessarily need to work on, but depending on the protocol, we'll sometimes throw some strep immunomodulation support that's more specific, but the overall immunomodulators can do the trick too, depending on the case. So those are all the markers. So it's a lot of markers. And so in my opinion, the NeuroZoomer Plus gives us a lot of really useful information. It's a very comprehensive test and I really love it. My one complaint about it, it's sort of a diluted complaint, but my one complaint about it is that it is a fairly expensive test, especially for us Canadians up here where our, it's a US lab, so it's in US dollars, and our Canadian dollar has been weak for many, many years now, unfortunately. And so it's a $420 US, at least as of the time of this recording, which is, recording this on August 14th. I don't know exactly when I'll post the video, but anyways, August 2025, $420 US. It's tax exempt for us here in Canada anyways. It includes the shipping cost. Again, with our patients, they pay the lab directly. We're not financially involved with the lab. So as I'm fond of saying, don't shoot the messenger. It's not my fault. It's so expensive. So I say it's kind of a diluted complaint because yes, it's a big chunk of change, no argument on that. However, when we look at what one is getting for like the value for money on this, there are other labs that test some components of the NeuroZoomer Plus. And a lot of those labs are much more expensive if they were to be done individually. So for example, if one was to do a Cunningham panel, my understanding is, nowadays that's around $1,000 US to do that. If we were going to do a panel, like a viral panel for, HHV6, HHV7, Epstein-Barr, cytomegalovirus, like through the standard labs that we use when we're just testing for viruses, that's easily going to be like, yeah, $400 or $500, Canadian anyways, because we use a lab in Germany, which is a great lab called Armin Labs. it's when we convert into euros. So yeah, I guess it would be around $300 US or something like that. So it's when we kind of piece this all together, and that's just looking at, certain markers. That's not looking at all 47. So if we were to test for all of these different components individually, many of these tests, I don't know where else you would get them done, to be perfectly frank. The $420 price tag, like it is, in my opinion, for what you're getting, it is very reasonably priced, but it is still really expensive. So just to put it into context, I don't want to throw the lab under the bus saying like, oh my gosh, they're padding their pockets. I mean, of course they are, because they're a lab, and it's a capitalist society world that we live in. But I don't think that they're gouging people on the price is what I'm ultimately driving at. So that's what you're looking at cost wise for the NeuroZoomer Plus, and that's what a report looks like. As I was going through the report, I realized that I underestimated the amount of time it would take me to go through this report. I genuinely thought I'd be able to get through two other reports, but um, I have a patient coming in soon, and I don't have time to go over the other reports. So I'm going to officially call this a part one, and I will go through the other two reports in part two of this podcast episode. So I hope that this was of interest. If there are questions or comments about this, please feel free to post in the comment section below if you're watching this on YouTube. If you're listening to this on a podcast platform and you have questions or comments, then feel free to email my front desk. Feel free to find this on YouTube and just post the comments on there. I do look at all the comments and questions, and I will happily get to them when I'm able to. And yeah, I thank you for your attention, and I will leave it there for now.